Okay, my name is Michael Weaver, and I'll be talking to you today about conversion total hip arthroplasty following failed hip fracture fixation. Certainly a challenging situation, and one I'm happy to share some of my thoughts about. A little bit about me and us. This is Harvard Medical School, so I work in the hospital just behind this building. This is the one day of the year that it actually looks beautiful like this. The rest of the day, it's a little bit more gloomy. And this is the hospital that I work at. This is the Brigham and Women's Hospital in Boston. This is the rest of Boston, kind of a great city if you get a chance to visit someday. And then these are my partners, Dr. Von Kudel and Dr. Suneja. We're the three people that do most of the fracture work at the Brigham. So conversion hip replacement, particularly in the setting of previous fracture fixation, really represents a wide spectrum of cases with issues both on the acetabular and the femoral side. And these can be really difficult. They're difficult because of the distorted anatomy and the previous metal that's in there. And so they require a thoughtful approach to get through them. So the goals of today's talk, I want to talk about kind of three things. One, the workup for infection, which is particularly important in the setting of a previous surgery or fracture fixation. The importance of planning these cases, because these are not routine cases, and templating, and something that one of my new colleagues, Dr. Stenquist, calls chair flying, which is something from the aviation injury, which I think is particularly important for this. And then stem choice. You know, there's a lot of different options. You can use primary stems for a lot of these, and then revision modular or even revision monoblock stems, which I particularly like for a lot. And then the use of cement definitely has a role. So I'll give you a series of cases to kind of illustrate some of these topics. So this is a 62-year-old gentleman who lived in Western Mass, which is a little bit away from our hospital. He had an acetabular fracture that was treated non-operatively, and he came in about a year out, and he has this significant protrusio deformity. You know, this was primarily an anterior column fracture. You know, the advantage here is no previous surgery, but he's got quite a deformity. You can see he's got a significant protrusio, and the femur is acetabular, or the femur is medialized quite a lot. There's also this really large medial acetabular defect. This patient is short and very stiff, right? So this is a little bit of a challenging hip, but this is not a primary. And in a situation like this, you know, I think getting a CT scan, if you can, is very useful. If you can't get a CT scan, then Judage views will actually do the same thing, which is really show you, in this particular case, that we're lucky and that the posterior column is undisturbed and intact, and the anterior column is healed. So it's really a protrusio without a segmental defect or without a discontinuity. So this is where I think planning is really useful. You know, like if you approach this case like a primary hip, it's going to be a very tough day. But if you plan it out, things go a lot more smoothly. Here I'm planning a posterior approach, which is what I use for the majority of my complex conversion cases. In situ neck cut, because this patient is really stiff. Then I want to restore the hip center. And to do that, I'm going to need to use augments or something else. I have heard some people using the femoral head as an autograft, but I personally prefer metallic augments when possible. And then I selected a Wagner stem, which is a monoblock, cylindrically tapered stem that's very useful in these situations because it really lets you control version, although certainly I think a primary hip stem would be fine in this situation as well. You know, a lot of my work is trauma surgery, and I do a lot of fracture work. And so Jeff Mast is one of my idols and icons, you know, and so he said, better to throw your disasters into the waste paper basket than to consign your patients to the scrap heap. And that was to advocate templating and preoperative planning fracture cases. I think the same is true for arthroplasty cases. So I think planning things and doing a good template is well worth it. The other thing that you can do is something called chair flying, and this is something they do in the Air Force here in the United States, and pilots do. And so when you're training to be a pilot, apparently they have a lot of time spent just sitting in a chair, thinking and going through in your head each step that you're going to do. And so before you even get into a cockpit, you're kind of practicing and rehearsing these things in your head. So here we are in the middle of the case. I use a lot of fluoroscopy, and I'll get into that in a little bit. But, the beginning thing is to ream up the defect to get down to good bone, and then ream the native acetabulum to get a good rim fit, and then place your augment trials. And then I like to use the reamer shell as a template to kind of really see things. So here you can get a sense that there's the augments placed medially, and then the reamer shell. And you want to make sure those augments aren't interfering with the press fit of your primary cup, because you want a good sticky fit if you can with your acetabular shell. And then finally placing the components, and you still need a good press fit of that primary acetabular component. The augments really fill the metal void and are there to provide stability and prevent migration of your cup. Then lots of screws. This is a situation where I'll put almost every screw that I can that doesn't interfere with the augment into decent bone. And so here we used a good, I think it was 11 screws. So maybe overkill, but certainly doesn't hurt to get extra fixation. And then you need to mechanically link the augment to your shell. And so I use antibiotic Palico cement to kind of fill that void and link them mechanically. So this is our final results with our PACU film next to our template. So I think this just shows the power of templating. I was able to restore the hip center to where I wanted, and restore leg lengths and offset. So by templating a case and then executing that plan, I think you can get decent results. And this is a year later. He's doing okay. He has no hip pain, and he's back to chopping wood and doing all his normal activities. This is another case that kind of illustrates some of the issues with infection. This is a 64-year-old woman who presented with a prior periprosthetic fracture. She had a anterior approach total hip, and then had that revised for a fracture at another hospital, and then presents with a draining wound. So here, this one that's clearly infected, but we got an aspiration just to confirm it. I think having a good micro data is really important, particularly for antibiotic selection. And then, everything needs to come out. I really do believe in a two-stage approach for infection. So if it's fracture hardware, previous hemiarthroplasty, or fracture implants, if there is an infection, then I take everything out, treat it in a two-stage manner. So remove all the metal, place antibiotic cement, and then treat the infection. And that's what we did here. So she required a long ETO, given that long stem. Out comes a stem. And then out comes a cup. And given the long ETO, I used a static spacer, although certainly if you can get a good mobile spacer, I think that's reasonable too. And then 3 months later, we go back in and place the stem. Unfortunately, there was a little crack distally, so I augmented that with a couple extra wires just to stabilize things, kept her touchdown weight bearing for 6 weeks. But everything healed without any subsidence, and then she was doing well a year later, back to fishing. So again, I think being conservative with infection is definitely worthwhile. And so I do favor a two-stage approach in revision and conversion cases. One thing that I've learned a lot about is fluoroscopy. And this is something that one of my mentors, Mark Veris, taught me. This is a paper that we wrote up years ago, looking at using fluoroscopy to improve component position. There's certainly a little bit of a learning curve. But, we fix almost every fracture with fluoroscopy now. And so I think using fluoroscopy for hip replacement is very reasonable. It definitely helps with cup position and femoral component position, as well as reduction for a lot of these complicated things. The key thing is to use a large C-arm with a large head. I use C-armor, but you really want to be careful with your sterility of the C-arm. When you go back and forth to a lateral, there are a lot of studies to show the drapes aren't quite as sterile as we would like. So really be careful. The key thing to this is really getting the right fluoroscopic image. You want to match the view of the pelvis as far as inlet, outlet, and rotation, so that you're matching your pre-op film and your template film, so you're not surprised in the PACU. If the image is oblique on the fluoroscopic image, you may like the position of the cup or your components, but then when you get a true image in the recovery room, it may look different. And so you really want to focus on matching those two things. So this is an example of a woman that had a bilateral fracture dislocations of her hip that we treated with open reduction internal fixation. She did well initially, but unfortunately developed AVN on the right the right-hand side with collapse. I check inflammatory markers, ESR and CRP on everybody. These were elevated a little bit, which is not surprising. So, we got an aspiration. Fortunately, that was negative. But I still follow up and get cultures in the operating room from the definitive surgery, and then also keep people on antibiotics for 10 days post-op, just oral antibiotics while those cultures are resulting. So this is somebody that had a lot of metal on their posterior column. I do try to remove that if it's feasible. It does add a little extra time, but once in a while you will have that surprise positive culture from your case, and then you feel a lot better if all the metal is removed. So I went ahead and exposed that. Certainly you got to be careful with the sciatic nerve exposing the posterior column, but it's time well spent, I think. And so then once we got that out, we're able to basically do a primary hip for this woman. So place the cup. I do use a lot of screws just to be on the safe side, given her previous fracture and issues. And then this is the result. So an example of kind of being careful with your infectious workup, and then removing the metal to reduce the risk of infection post-op. A little bit more challenging conversion following an acetabular fracture. This is a 54-year-old gentleman. He had a remote history of an acetabular fracture, much more deformity here and some heterotopic bone. But fortunately, his infectious workup was negative. And so again, when possible, remove the implants. It's important to take down all the heterotopic bone and osteophytes you can. You can see there's quite a lot here. In general, I leave anything that's flush with the cup, but if it's proud of the cup, then I want to remove that to reduce the risk of impingement and dislocation. Here we had to raise his hip center slightly, but we were able to make that up on the femoral side and kind of put things back where they belong. Again, it's a little bit of extra work to get that metal out, but it's time well spent, I think, to reduce that risk of infection. Moving on to kind of the femoral sided issues. This is a gentleman that had a hip fracture fixed with an intramedullary device, which is now the kind of standard of care for most intertrochanteric hip fractures here in the States. Here, unfortunately, you can see there's AVN and cutout and some erosion into the acetabulum. Fortunately, that erosion is pretty small, right? So this is an example of using a modular stem to deal with that. With these small defects, we don't need to worry about bone grafting it or augmenting it here. Another case of a gentleman, this time with a hemiarthroplasty, cemented hemiarthroplasty. Again, I check inflammatory markers on everyone. I just make that a habit. And, we do an aspiration, and, fortunately that's negative. The cement mantle is broken and subsided. So that's definitely loose. That all needs to go. And then, if you're going to revise this, you might as well go to a total hip. There's no reason to keep him at a hemiarthroplasty. So, sometimes getting that stem is hard, but we have cement removal techniques. I use the Moreland cemented implants with reverse curettes to get that stuff out, and then go ahead and put in the cup. Again, this is essentially a primary situation on the acetabular side. This time, only a couple screws. And then using a extensively porous coated modular stem. With these cylindrical stems, you need 5 centimeters of press fit or a scratch fit to really engage with the diaphysis. And so this is his final result. You can see that we were able to restore his leg lengths and offset, and again, he healed. I do use dual mobility over the last few years to optimize stability, particularly if you're converting a hemiarthroplasty. The risk of dislocation is pretty high. Another example of a cutout of a femoral nail. Again, infectious workup. This is one where the area of erosion into the acetabulum is small, and so I think you're going to avoid a defect that needs to be grafted. Sometimes they'll put some of the bone graft from the femoral head and reverse ring that in, but certainly don't need to go to any great lengths. And then as far as the stem choice here, I used a monoblock revision stem. This is called the Wagner stem. They come in shorter versions, and then this longer one, which is called the Wagner SL. It's cheaper than using a modular revision stem. It has less bulk proximally. It's got the smallest proximal geometry, and so it's a real elegant solution for controlling version, controlling offset, and then not really disturbing the proximal femur and the greater trochanter. I find these previous fracture cases, you're really worried about the greater trochanter, and this is the least damage that you could do to that to get a stem in. And so I like the stem for it. It's essentially you just ream it and put it in. It's really nice. So you just ream it with conical reamers, and then you have different trials. It does tend to sit up slightly, but that's something you get used to pretty quickly. And you just trial without broaching. So you just ream and trial and then put your real implant in, and it works out really nicely. And so this is the final result with that. Again, you can see the proximal geometry is as small as you can be. There's no big bulky body there to ream out the greater trochanter, and so it works out quite nicely. Sometimes the acetabular side is a little bit more complicated here. This is a woman with an infection and an unusual oncologic problem. She had a septic hip. Given her need to be treated for her cancer, I just did a resection arthroplasty on her and got her through her infection. But a year later, she's in remission and she comes back. And again, always make sure there's no sign of infection. Here, clearly she had a previous infection. So even though her inflammatory markers are normal, we aspirated her to be on the safe side. And then again, this is a great use of the Wagner stem. The proximal femur gets worn down a little bit after a resection, and it lets you control the version to optimize stability, which is always a worry in this situation. So I think it works out very nicely. Sometimes, you've got really frail patients. So this is a 97-year-old woman with a hip fracture treated with the nail. Unfortunately, it cuts out. There's no sign of infection, but she's really frail. Here we have a geriatrics co-management service, and she had a frailty index of 0.56, which is extremely frail, right? So in our situation, this would be kind of someone that's end-of-life care. But she has pain and she can't walk, so we need to do something to make her more comfortable. So we do a total hip. I think, some of these do require grafting the acetabulum, but if you have a less than 50% rim defect, you can get away with a primary cut, but I just go ahead and use lots of screws, and particularly long screws, to engage the bone and provide as much stability as possible. And this is really where cement comes in. I think it's really useful. You can use antibiotic cement to reduce the risk of infection. And the bone quality is poor. And by using a longer cemented stem, you get instant fixation, and this person can be weight bearing immediately and kind of get on with things. So, she actually did pretty well and was back to walking with a cane. And at least we provided some quality of life towards the end of towards the end of things for her. This is a more challenging cutout, particularly with the greater trochanter. So this is an 87-year-old woman who had a fracture repair a few weeks ago. I think, this just goes to show the best way to do a conversion hip replacement is not do one at all by doing a good job the first time. So if they had fixed this a little bit better, hopefully we wouldn't have been in this situation. But you can see this is really challenging now because the head is all cut out and the trochanter is really an issue. That's going to be hard to manage with this. And so I use a technique. It's actually an old technique that Charnley described for fixing the osteotomies that they used to use on every hip. And so essentially, by using cement and using drill holes, these are just cerclage wires around the greater trochanter to hold it down and in place. And it works out really nicely. You drill the holes and place the wires before placing the cement. And so that just is a really nice technique for controlling the greater trochanter. So the steps there are you just ream and broach the femur. The trochanter is kind of sitting aside. Then you remove your broach and drill holes in the appropriate spot laterally in the femur. And then you just loop wires through the junction between the tendon and the greater trochanter, and then through those drill holes. And then you select a size stem that's a little bit smaller. I downsize 1 or 2 sizes from what I'd normally place. Then I use that broach. I put that broach down just to make sure those wires are really pushed over so there's room for the cement mantle in the stem. Then you just go ahead and place your cement and cement your stem in place. And then once the cement is cured, you reduce your hip and then just tighten up those wires, and then trochanter just comes right back to where it needs to be. It's a really elegant technique, and it works really nicely. And this is her 6 months later, and you can see, we were able to control the trochanter. It healed in position, and she's doing okay clinically. So reasonable salvage for this situation. So cement definitely has a role, and I really like this Charnley technique for managing the greater trochanter. So I'd just like to say thanks for having me from the Harvard Trauma Service. I just wanted to share these cases with you to give you a sense of some of the different ways of getting through things. And again, if you're going to take anything out of this, I'd say the number one thing is just when you are confronted with these cases, always rule out infections. So everyone needs a ESR and a CRP. Anyone with elevated markers needs to get an aspiration preoperatively. I think at the time of surgery, always get cultures. And then if there is an infection, and you detect that preoperatively, then, treat that in a two-staged fashion. If you get positive intraoperative cultures, then there is an advantage to removing all your metal at the time of surgery to reduce that risk. The second thing is always template. A template and preoperative planning go a long way in these complex cases. Certainly, I've learned a lot from my templates, and I've gone down rabbit holes that are not good, and you can identify that before you go into the OR, and I think that does your patients a good service. And then the last thing is I really think it's worth considering using these monoblock stems. They work out really nicely. So a revision monoblock stem is a great solution for a lot of these. Thank you very much for having me, and I wish you the best.